Welcome to Oncology Today, a special three-part edition on the role of HER2-directed therapy in the treatment of HER2-expressing cancers. This is medical oncologist Dr. Neil Love. For this edition of the program, I met with Dr. David O'Malley from The Ohio State University and James Cancer Center in Columbus, Ohio. To begin, I asked him to present and comment on key abstracts on HER2-positive gynecologic cancers.
Hi, I'm Dave O'Malley from The Ohio State University and the James Comprehensive Cancer Center, where I'm honored to lead the Division of Gynecologic Oncology. I'm really excited today to talk about the role of HER2-directed therapies across really the treatment paradigm of GYN cancers. I think as we go through this, we're really going to talk about some of the prevalence of ERBB2 amplification, but also HER2 expression in really 1, 2, and 3 plus. And where are we in the current treatment testing recommendations and really the treatment recommendations leading into the efficacy data? And very important as we look at these new agents is what are the safety and toxicity concerns as we learn more and more about the antibody-drug conjugate landscape. You know, one of the things when we really look at GYN cancers, we know so many of them mimic our breast cancer patients. And we really need to learn from where they've identified their agents. And we have, from the first line therapy of Trastuzumab, and as we move forward in these new oral tyrosine kinase inhibitors, but also the antibody-drug conjugates, the true antibody-drug conjugates that we'll discuss. But we have this whole new sequencing of these of drugs, and how are we going to utilize these as we have these new class of, for example, the new Fc engineered antibodies as we move forward. So this is really a schematic, a nice review from Open Communications last year, I guess a couple years ago, really looking at what are some of these new agents that are directed at anti-HER2 therapy. And again, we've talked about these in the upper left, antibody-drug conjugates. We're seeing some bispecific antibodies come, and we also have the oral, or not, I shouldn't say oral, but most of them are tyrosine kinase inhibitors. But is there a role for immune therapies or even vaccines? We've done some work here at Ohio State in vaccines against HER2. So as we look at really what are the prevalence rates across our tumor types. And it's really interesting because we haven't tested as widely outside of uterine cancer. We really are not as clear on where are we in the prevalence. Most of our work has been in serous cancers. And again, this is a nice database looking at the foundation medicine and the expression of ERBB2. Again, but this is from the molecular. This isn't the expression using IHC, but pretty consistently across serous cancers of the years. Again, a rare subtype of uterine cancer, but the most aggressive subtype. It's at least 20%, and it's up to maybe as high as 40% in some serous cancers of the uterus. Now, when we look at endometrioid, that number is much lower. But again, because we haven't tested as widely, we're not even sure of where are we in that overall. So it's probably less than 5%. And when we looked at large databases, it's pretty consistent in that number. But again, we haven't tested as widely as we should have over time. And how about when we look at really amplifications versus rearrangements versus short variation, most of these ERBB2 are going to be amplifications. And this is probably the most complete publication that we have with regards to what are our guidelines in endometrial. This is specifically to serous cancers, but really could look beyond them. And we're really looking at, in the far left in the red box, strong, complete basolateral lateral membrane staining greater than 30% of the tumors. That's your 3+. And then if it was strong, complete, or weak in greater than 10%, that's when we're 2 plus and equivocal. And then we would use the fish looking at the copy number. And the copy number greater than or equal to 2, okay, or with an average of greater than copy number greater than or equal to 6 per nuclei, that was considered positive. So we kind of use those numbers, the ratios versus the copy numbers, to say, is this positive? And we really looked at that and used that and continue to use that. But is that what we should be using? It is in the current standards and what we're looking at, and it was endorsed by the NCCN in 2019. But when we look here in the green box, these that are low, okay, so once again, so the ratio less than 2 or copy number less than 6 per nucleus, okay, or the IHC less than 10% of tumor cells or very faint, those are 1 plus. And if you see no staining, 0 plus. So really, we know those positive, which are 3 plus or fish high expressions, versus those that are negative, but are they really negative? They're just lower expression, versus those that are truly negative with no staining in the tumor cells. And to me, those are the ones that are truly negative. But we really don't know how we should be. So when I've looked across all of these subtypes, I've really tried to say, okay, where are we in truly the prevalence? And so when we look at carcinosarcomas, again, taking a series of the old scoring in the 2007 scoring, carcinosarcoma, another rare uterine subtype, that our expression rates, and again, this is using FISH amplification on this, okay, FISH amplification, that we have about 16%. And you see here again, going down small numbers, 3 plus, 2 plus. So again, in a rare subtype, what are those? But we really don't know. And we look at the breast cancer, which is what we adopted for the serous cancer. But now the most recent, we'll talk about the pan-destiny tumor where they use gastric, or should we use the colorectal, or what we did in our trial with the serous cancer on the far right. So again, very inconsistent. And I will tell you, many GYN practitioners are not even sure of what their pathologists are using. So this is a small poster, but I think it really shows, to my earlier point, that we don't know if we don't test. So this was a poster that looked at their utilization of HER2-directed therapies and broke down small numbers. It's 39 patients, right? But half of them were serous, about another 20% were carcinosarcoma, but a high grade and what they call ambiguous features, so just high grade endometrioids, were about a third of those patients, and they even had one low grade. So once again, we really have not standardized what we would consider, who we should test, and what we would consider positive. In this case, we had amplification by NGS during for that trial. Okay, so once again, where are we in other tumor types? Same application here. We looking at HER2 positive ovarian cancer and the different criteria which are used. Varying degrees have been described. As I said, Destiny Pan tumor, which we'll talk about, use the gastric guidelines. So as we're going through these, we really need to look at and say what was used. So the Gyneco group looked at 320 patients. This is an older trial. And they used it IHC and FISH with using the breast data, and their cutoff was 2 or 3 plus. And across all ovarian cancers, about 13%. But again, maybe underrepresented with using the breast cancer data. One of my favorite trials is at the bottom. Bookman looked at within Trastuzumab. We were able to screen all of ovarian cancer patients. Again, using the complete membrane staining, the breast cancer data. When you look at the 2 and 3 plus, okay, 11%. But when you included HER1 plus, HER2 1 plus, excuse me, it was up to 30%. So again, and if we look at right above that, somewhere between about 15 to 20% using either breast or gastric across these different trials. So higher prevalence than we've talked about in ovarian cancer. Well, how about in cervix cancer? Again, looking at a series of trials, and this actually was a nice little paper looking at if they're ASCO CAP compliant, pathology compliant, that the prevalence of HER2 positivity in cervix cancer is only 1.2%, but it was reported at about 6%. So lower in cervix cancer, but again, unclear in is what we're looking at in these testing strategies. But what's going to drive down that number is if you include all cervix cancers. Really, HER2 is a non-squamous cell finding. And I've highlighted here in the red box HPV-related adenocarcinomas, the prevalence, again, somewhere in this, depending on what you're using, between 5 and 11%. And all these are rare tumor types. If we just look at the squamous cell, it's probably less than 2%. But again, with what we're finding here, I think it's probably worth testing. And this is really reiterating that this is a non-squamous cell. So this is this is a nice report looking at gastric cervix cancers, very rare type. But on the left side, you see, again, looking at, this is ERB2, so next generation sequencing, it's about 9%. But when you look at the usual HPV-associated adenocarcinoma, end up about 25%. So again, we're seeing different mutations in these adenocarcinomas, which are much higher than all of our cervix cancer together.
I guess the thing that we really want to know, or like one of the things we want to know, is do we have a patient in front of us who could benefit from T-DXd specifically? I mean, we could talk about other anti-HER therapies, but certainly T-DXd is on the table, so to speak. And I guess theoretically, if you believe that responses can occur in your patient, whether they have cervical or ovarian or endometrial, and you don't want to miss the possibility that somebody might be sensitive to T-DXd specifically, I might put out the thought that if you really want to be sure of that, you would need to get IHC. If it's not 3+ or maybe 2+, but I think 3+ to get FISH. But also, theoretically, you might want to do an NGS looking for HER2 mutations, because we know, particularly in lung cancer, that respond extremely well. I mean, we don't know for sure outside of that. Any thoughts about whether HER2 mutations should be on the table as well as overexpression and amplification?
I think the expression from an IHC standpoint should be done in every single cervix, uterine, ovarian cancer patient. The results we're seeing right now are just too important. The next question is, as you've heard me say plenty of times before, I'm going to check next generation sequencing on every single my recurrent metastatic disease. Now, we need to, over time, figure out what is the better test. But the current landscape, finding those patients who have a actionable mutation or expression, protein expression, 100% of patients should be tested in is what I feel right now, in a metastatic recurrent setting. IHC and next generation sequencing. I agree 100%, Neil. And the responses we are seeing are profound. And to miss those patients when we're already doing the testing just doesn't make sense to me. I think we need to test for everybody. I agree 100%.
Well, when you put out the thought about the non-squamous, that's kind of what I was thinking, because then I was thinking to myself, well, what about lung cancer? But then lung cancer is all HER2 mutant.
Well, then you also think it's only 2%, but what happens if you hit? I mean, we're looking at we're looking at Lynch syndrome being 2% of endometrial cancers, but we test everybody originally because of trying to identify Lynch syndrome. Now we do it because of the response to immune therapy. So for me, once even that 1 to 2% in a test that we're already getting, these are we're doing this anyway. Why not test for it? I
Absolutely.
agree 100%. And that's a great segue into why am I saying that? So I start with our older data, and this was led by Dr. Fader, a good friend of mine and a collaborator going way back when she was a fellow at Cleveland Clinic and was a fresh faculty at Ohio State. And this really led to a randomized phase 2, which was uh, really practice changing from a randomized phase 2. And what did we look at? We used the breast data. They had to be positive, so 3+ or 2+ positive fish. Okay. And then we randomized them to our usual carboplatin paclitaxel plus or minus trastuzumab. Okay. And we included primary advanced stage or recurrent, and they could have had one prior therapy. And what we found on the two separate papers, on the left is the original publication at JCO, is that clearly the patients benefited for trastuzumab. And then when we looked at and we reported, because a lot of said, well, O'Malley, it wasn't blinded independent review, it wasn't placebo controlled. Your progression-free survivals are not reliable. Well, guess what? We wrote 2 years later our overall survival, looking at those with advanced disease, primary therapy specifically. We had a hazard ratio of 0.44. So clear differentiation that HER2-directed therapy improved our outcomes, particularly in patients without prior therapies. But we can do better. And we have done better. And we've looked at different ways. Again, our next generation of with what was called the Jupiter study, trastuzumab and pertuzumab. Okay. This was amplified. These were amplified. And we saw that the combination of those patients had about 22-23% response rate. Okay. And that was a trial across all tumor types, but clearly, again, showing that this is an actual mutation. The TAPPER study also reported at ASCO 2021, again, looking at patients with this same combination, but now instead of amplified, mutated or overexpressed, more modest response rate of 7%. Nothing really overly exciting there. And then when we looked at the NCI match, the TDM1, okay, trastuzumab emtansine, which I call TDM1, okay. So the NCI match, unfortunately, only showed about a 6% response rate, which we were a bit surprised at. And for those, and again, this is where it started to say those are next generation sequencing. So is that as good as the protein expression? Now, as we looked forward here into this next generation, the first signal we had about T-DXd was back in 2020 in an earlier all-comer trial where we really started seeing endometrial cancer patients with really impressive results. Dr. Banerjee then also published in 2019 with regards to 14 small patients, but a response rate of trastuzumab duocarmazine, okay, again, showing response rate at 50% and very nice waterfall plots. So we're seeing those signals early on in the experience. And then we had this publication, the status trial, looking on T-DXd only in uterine carcinosarcomas, HER2 positive, okay, and breaking down between the expression in the upper left-hand corner, okay, of what they called high expression. In this case, it was IHC 2 or 3 plus, okay, in the low expressions, 1 plus. And you see these water plots on the high expression response rate is 55%, but in the small number, only 10 patients, but you had a 70% response rate, PR, with almost every patient having disease regression. And you see those swimmer plots on the right. So not only are these patients getting responses, but those responses are persisting. And that is days on the right. And that was just published in GYN Oncology. Okay. So switching gears a little bit here and looking at our oral TKIs. Again, exciting option, okay? HER2 expressing cervix adenocarcinomas, all right? And when we look at, again, small subset of patients, but we did see a response rate in more than a quarter of the patients with duration response of about 6 months. So again, another mechanism with pan-TKIs that with the HER2-directed, and you see here the where you're looking at from mechanism of action in these patients in this disease, excuse me. But what really caught our attention is the most recent reports, both at ESMO and ASCO, with regards to T-DXd and the Destiny Pan tumor. And we saw this kind of basket trial. And the top 3 are endometrial, cervix, and ovarian cancer. Again, using IHC 2+ gastric type, okay, 2 or 3+, excuse me. If they would have to be tested locally and then sent in for confirmation. So the reason you have patients who are included in less than 2+ is because on centralized testing, those numbers were lower. And we're going to go into this a little bit more closely here. So I've just taken out the GYN cancers. And you see here from left to right, uterine cancers, 85% at 3+, 47% at 2+, and all comers 57%. Go over to cervix, 75% in 3+, 40% 2+, and 50% in all comers. 64% in ovarian, 3+, 37% 2+, 45%. And now the swimmers plots, okay, are using months rather than days here. And you see patients with benefit going out for more than 2 years. Most of them, again, in that 9 to 12 month range. But what's really interesting is, again, looking at the benefit, the clinical benefit, even though the response rates, almost all patients are responding. Almost all patients are responding. And we see, again, these waterfall plots that are so impressive. The dots at the bottom of the waterfall plots are those that were 3+ expression. Again, endometrial, cervix, and ovary left to right. And we've already talked about the response rates. But this is what's really interesting to me. Okay. So I needed my daughter's help here, but she helped me with some algebra. In this supplement of the JCO paper, they have what the central review were all the HER2. So by utilizing what you know as the all comers, knowing how many responded from top to bottom, we know in those patients who are in uterine cancer, there's one unknown, okay, 0 or 1+, 40% response rate, 10 patients, 4 of 10 responded. Cervix, 12 that were either 0 or 1+. Now, interestingly, let's look at endometrial. There's 4 1+, 4 responded. There's 8 1+ in cervix, 6 responded. I don't know if those are all 1+. I just know 6 of the 12 responded. 50% response rate, 0 or 1+. Now let's go down to ovary. Interesting, there's 5 1+ and 5 0, 10 patients, 4 responded. 40% response rate, 0, 1+, or unknown. They did not say of those that responded in those less than 2+, how many were 0 or 1+. Now, interesting, this led to the NCCN guidelines changing for cervix and uterine cancer. But interestingly, they only include 2 and 3+. But when you look at this, it clearly has activity in less than 2+, and you could argue just as good of activity as it is in 2+. So this comes down to our earlier conversation, Neil, with regards to what is the right test here? What is the right test?
Well, if you want to say that T-DXd causes responses in people who are HER2 low, then you'd have to get a FISH according to breast cancer. You don't know whether those 1 and 2+ are FISH positive, correct?
Well, this is what's really interesting to me. And I think as we see the breast cancer data developing, if you had that 1+, at what fish cutoff would you then utilize? Okay. Or is 1+ enough? Is any protein expression, any membrane expression enough for you to get activity? And this is some of the data, again, it's such small numbers. We have to put this in context. This is 40 patients, and I'm talking about groups of 10 and 12 patients here that I'm making pretty big jump. But it's very interesting to me that we need to really look at these patients, enroll a lot more patients at 1+, answer the question about, do you need fish to predict response? I'm not sure we do.
Right. Well, it's just interesting though, because you've got some docs who are going to be taking care of all these cancers, not the gynecologists, but the medical oncologists. And for them, I don't know, maybe some of the gynecologic oncology, I don't know if they ever take care of breast cancer, but I don't think so. But the point is, HER2 low in breast cancer means fish negative. So I'm not saying what's right or wrong. As a matter of fact, this actually makes a lot of sense. I like this, but I'm just pointing out it's different than breast cancer. So
Well,
the doc who's
yeah.
getting used to treating HER2 low breast cancer, when they look at this, are going to be confused.
Well, and I think from when this is more thought provoking from my standpoint. And I'm saying we should treat everybody at 0, 1+. I don't think I'm willing to take that jump, but I think it's very interesting as we see more data evolving, maybe not revolving, over time. That do we need fish in a 1+, or is the IHC enough? And I think as we look at us talking to some medical oncologists who do a lot of, to your point, breast cancer, and I said, well, are you going to use this in 1+? And they're like, oh, absolutely. Now, I didn't ask the follow-up question is, are you going to test for fish before that? And that's a great question. And I think one of the questions we need to answer as we treat more patients more on clinical trials.
I mean, for the typical medical oncologist who has a breast cancer patient who's 2+, if they do a fish and it's over 2, they're treating as HER2 positive, period. If it's less than 2, they treat them. Nowadays, if it's less than 2, they treat them as HER2 low. But it looks like, and I didn't even realize this, I guess because it was a supplement or whatever, but so this is going to be very interesting.
I want to know what, HER2 low, where are we on those? And I'm going to be watching that breast cancer literature because obviously we have a lot more patients that are going to be HER2 low that may have the opportunity to benefit. But these drugs come with some side effects. And, I think we're getting comfortable. We are getting comfortable with dose reductions, with dose interruptions, and we're getting comfortable with the antibody-drug conjugates. I was a bit surprised when I first started utilizing T-DXd and the GI side effects, particularly in the first cycle, second cycle, until we really get them on mitigation strategies and we can make them feel better. Hematologic hasn't been that bad, but we see it. Okay. And then obviously, you will see some alopecia. I shouldn't say obviously. You do see some alopecia. Some of it can be profound in patients. So those are some the GI, fatigue, hematologic, and then also alopecia. But what's the thing that I really educate patients about, and we've heard about, the interstitial lung disease pneumonitis. As we look at here, this is across the entire destiny, not just the GYN. That's an important point, I should say. But 3 patients with grade 5, okay? Any grade about 10%. More than half of those were grade 2, so symptomatic. And we will need to dose interrupt. And so actually, when we looked more at the pneumonitis, again, about 10.5% of patients, 28. And this is really what I was just alluding to, where we have 3 fatal, one in the endometrial, one biliary, one in the other. But over half of them were symptomatic, and only about a quarter of them were asymptomatic in findings. But even asymptomatic patients, Unlike, with mirvetuximab, if I have an asymptomatic patient, I tend to treat through. That should not be the case with T-DXd. And this is a really, really nice paper. Really nice paper. Really talking about ILD and looking at TDM1 and T-DXd. And again, where are we in and what do we know? And we don't know a lot. We don't even know the mechanisms of action and why. Is it because of the payload release? Is it the bystander effect? Is it some other targeted uptake within the lung? We really don't understand it. But the early diagnosis and intervention we have figured out is key. So again, on the right hand side of the table, looking at overall ILD, TDM1, you're looking about, again, 2.5 to 4%, TDXd higher at 10 to 15%, but the fatal at right about 2.5% in TDXd, not as high in TDM1. Now, how about the treatment? Again, from the same paper, really nice summary here. If you suspect it, in educating patients about the side effects, so important. So educating them and then practitioners monitoring them. If you suspect it, get a CT. Consider pulmonary consult. If you need to, get blood cultures, bronch, even PFTs. Okay, am I doing that for all of my patients? Well, if they get admitted, many of them. Think about ABGs. Okay. And, this has been brought up in the paper. I have not done this, and I'm going to need to think about doing this. Is do you have the opportunity to do PK assessment in those patients and make sure you don't miss other causes, obviously, across that? So, in the summary on the right, okay, so grade 1 TDXD, everybody should get steroids at about 0.5 mg per kilogram per day. Okay. And continue that for at least 28 days. Very important point. Different than IO-associated toxicities here. Make sure you continue in 28 days. If it resolves less than 28 days, the recommendations are you can maintain the current dose. If it persists beyond 28 days, then you should dose reduce once. But again, make sure you have the steroids over 28 days. The recommendations of TDM1 grade 1 are permanently discontinued. Remember, that's just a CAT scan finding asymptomatic. If they're symptomatic, 1 to 2 milligrams per kilogram per day, okay, and maintain that for 14 days. Unlike IO, where we try to, once they get better, we try to decrease that. That needs to be maintained for at least a couple weeks, and overall, and then taper for at least 4 weeks. Really nice paper. I just read this again, and I really applaud Dr. Tarantino on a really nice paper. So in this new era, it's amazing the options we have, and it's exploding. We're just learning about NGYN cancers, our breast cancer, our gastric cancer patients, teaching us much more. Selecting everybody biomarker. Neil, I agree with you 100%. I'm testing everybody for IHC. I send every recurrent metastatic disease for NGS anyway. So I'm looking for those and really identifying patients who are going to benefit the most. Clearly 3+, but really looking at the NCCN and 2+. But I believe we shouldn't exclude people with 1+ moving forward. We need to identify those patients who are going to benefit. Don't forget toxicities, GI, hematologic, okay, even alopecia. But pneumonitis is a toxicity that can kill people as high as 2% of the time, particularly if we don't recognize it. The biomarkers we're using now to select these patients, and most importantly, the drugs we're utilizing now are so much better than the previous drugs we used that were targeting HER2, excuse me. I'm really excited moving forward for great opportunities for our patients.
Awesome. That was great. So let's go through your cases.
So this is, I tell you, I think when we really look at the opportunity for HER2 new, clearly we're well ahead of testing HER2 status in uterine cancer. And this is a patient who transferred recurrent uterine cancer. She transferred care in her 60s, actually a move from a warm weather state to Ohio. I don't know what she was thinking, but I don't think, Neil, you'll be doing that. You're just
No, I'm
so
here forever.
yes. So she had stage 3C disease with 2 positive lymph nodes and a carcinosarcoma. She was treated her previous institution with chemotherapy, paclitaxel, and carboplatin for 6 cycles, and also received whole pelvic radiation. Very, very reasonable. You could argue the whole pelvic is controversial, but you'll see from the next case or two that I also use whole pelvic in these high-risk patients based on some of the PORTEC data. Had a questionable CT at the completion of her chemotherapy, and then shows up to me and transfer of care. And I say, well, let's repeat this CAT scan just a few months after completing therapy. And unfortunately, at that time, a questionable CT had become a clear recurrence. We did biopsy to confirm recurrence, but she had widespread disease and a patient who had already received chemotherapy. So her HER2 score was 1 plus. And again, we would say a low expressor there, right? I sent off next generation sequencing. Unfortunately, there's no actionable mutations at that time. And so she was offered study on an NCI CTEP trial with T-DXd that allowed 1 plus expression to come onto the trial. And I talked to her about lenvatinib pembro, but said this trial was open, it's 1 plus, and I could use lenvatinib pembro in the future. She is tolerated quite well. And you see here her first scan at 9 weeks, she almost has a near resolution of a periodic lymph node. In her entire RECIST criteria is about a 54%, but I used a representative sample of a near resolution of a periodic lymph node during this time. So again, was well tolerated, had some of the GI with the diarrhea, did not require dose reduction, and is continuing to do well with a partial response.
Before you go
Now,
on, could I
yes,
just ask a couple of questions about that?
yes, sir.
First of all, could you tell me a little bit more about how she did on her first treatment? Did you use most people I hear, at least in breast, they use preemptive medication for GI toxicity. Did you use that with her, and what happened?
Yeah, no, we use antiemetics at the time of infusion. The diarrhea presents, that cycle 1, 2 in typically about mid-cycle, I guess about a week in. So it's really interesting. We're not mitigating because so many of our patients, we have the risk of pushing them the other way from diarrhea. And so if it does start, we're quick to make sure that we add agents, anti-motility agents. And so when I'm not using mitigation strategies for the diarrhea, but yes, we absolutely will use prophylactic dosing for nausea.
Right. And how far out is she at this point?
She is actually just saw her, and she is now right about cycle 9, so 27 weeks. And she is stable with her about 55% reduction in size. So she's at about 27 weeks of duration response.
And what's your plan in terms of screening for ILD? Are you going to use imaging of her chest?
So we don't typically, unless they have chest disease, we don't typically screen for ILD. And it's a great question. Maybe we should. Many of these patients, I shouldn't say many, some of them will have chest disease. We're getting that anyway. But if they have any symptoms, now you bring up a really good question. If we're saying for grade 1 we should treat, should we be getting CT chest on all of these patients? I have a hard time getting those reimbursed, so I haven't gone that route unless I have some concerns from a symptom standpoint, in which case I have a order CT the chest. But it is a really, really good point. We haven't taken that step yet, but maybe consideration in the future.
It seems like the breast people do it, but kind of outside of breast, it was like you. It's kind of hit and miss in terms of what people are doing. The breast people are going to image their chests like at a minimum every 12 weeks. I mean, for a long time. I don't know how they get it paid for, but that's what they do.
Well, I think, with depending on where we're seeing, if we're really seeing a 10 to 15% over time for any grade ILD, it really will need to become a consideration, particularly because we know early intervention is going to improve the outcomes, and it really is something we need to consider moving forward.
Well, that's the other thing, and I always bring up the breast algorithm to the GI people, to the lung people, everybody else, of once they have symptoms, they're not getting T-DXd again. So you got to get it at grade 1, but that's the breast people. How about, would you retreat somebody who had any symptoms?
I haven't had to face that decision because many of my patients are right now being treated on clinical trial. So I just started treating, and actually the next case we're going to discuss is off-label usage. So if I had a patient with very mild symptoms and they returned to within 4 weeks, and they had a patient, again, these are metastatic recurrent patients. They don't have a whole lot of options, particularly uterine serous and carcinosarcoma, fairly chemotherapy resistant patient population. I would most likely have a discussion. I haven't had to face that discussion yet, but I put a slide up there that says not to retreat. But if their symptoms were very subtle, I would have that conversation. But you really bring up a fantastic, fantastic question, which is if we identify this prior to symptoms and we can maintain, I really think it's something we need to consider. And to be honest, until this conversation right now, I hadn't considered it. One reason I love doing these sessions with you, because I learned so much from your interviews with other specialists that will continue to learn and teach me.
Yeah, I'm just passing it along. I just did an interview with Dr. Tarantino the first time I just met him. How many people roughly have you treated with T-DXd?
I was thinking that as I was putting these cases together, and personally, I'm probably not quite at 20 yet. Somewhere between 15 and 20.
Right, and those are pretty much on trial. So interesting. The other thing that's interesting to think about is, she ended up getting treated or getting put on this trial, as you said, before getting lenvatinib pembro. I'm kind of curious how her clinical course compares to what you think she would have had if she had a lenvatinib pembro.
Well, I think this particular patient has tolerated it quite well. And so lenvatinib pembro is, as you know, I've been a big advocate of utilizing that combination, but it is challenging from a symptom standpoint. So from a symptom standpoint, I think the T-DXd was better tolerated, but for my sequencing, if this clinical trial wasn't available, I probably would have sequenced lenvatinib pembro before the off-label use of T-DXd. You could argue with me, and this is discussions that we have across the country about, how are we going to sequence if we have a patient? If a patient's 3+, am I going to sequence that before lenvatinib pembro? But this particular patient was 1+, so she's not included in the NCCN guidelines. So there's a good chance I would not been able to give it off label. And so the only opportunity for her to get the drug was to be on clinical trial. Potentially the only opportunity is to get the drug on label. And so for me, knowing this trial was going to close, I had talked to her about those options, and clearly it has benefited her. And it continues to benefit her, and she knows that her next treatment regimen will be lenvatinib pembro. We've already talked about it.
Yeah, that's really interesting. You know, when you first presented it and said she was going to get treated with T-DXd before lenvatinib pembro, I'm like, whoa, that's interesting. But she did great, and maybe that's where we're going to land in a few years. Who knows? The thing I really want to know, and I think, I mean, maybe I'm crazy, but I think you could get this case written up if you just did a fish on her. If her fish is less than 2, you could write it up.
Well, I tell you, again, this is so early on in experience that every time I have these conversations, I learn something. I've learned two amazing things tonight, which is, should I be considering CT the chest on everybody? And I should be ordering fish. I haven't been ordering fish because once I have the 2+, I don't want to know what the fish is in case,
Yeah, no. I'm not saying you should, definitely not for patient care, just for science. I think it'd be, I mean, you saw one patient who had a really good response, who was really HER2 low. The next time you have a patient, it'd be pretty hard not to try it if you could get it. I don't know, but I don't know. I just think it's really fascinating. And this case is incredible. Yeah, and I don't think it would help you to treat her, or it would have helped you even in the beginning necessarily. But now, if you know that she responded, if you could find a few cases like that, it'd be even great better. But really interesting.
Well, I think, and she's been treated on protocol, so we will get information like that from these patients.
One other thing before you continue on, just to sort of take your current pulse in terms of sequencing and metastatic endometrial, as we've been talking about now since the SGO meeting. Where are you right now in general of your metastatic patients getting IO first line?
Well, hands down, DMMR is IO in the first line. The PMMR, when with the data that presented at Ruby and GY18, looking at those patients who are P53 mutated, as well as serous and other histologies in the GY18 presentation, for most patients right now, I am offering and encouraging IO therapy with carboplatin paclitaxel. The one group of patients, and I say one patient because I just had this conversation, is in a patient who is P53 wild type, particularly those low-grade endometrioids, depending on where they are in their treatment journey. I have a patient who had a completely resected, isolated recurrence that she decided not to move forward with IO therapy. But if I had a patient with widely metastatic disease, I probably would encourage IO therapy, just because we know that a certain group of patients are going to really benefit markedly from the IO therapy when combined with carboplatin paclitaxel. So almost all patients I've moved to encouraging and definitely offering, but encouraging IO therapy with carboplatin paclitaxel, with the exception of P53 wild type, particularly those with grade 1 endometrioids. I know that goes a little against some of the GYN18 data that Rama has presented at ESMO, or IGCS actually, but I do believe that's a group of patients we need to continue to evaluate on clinical trials and look at other alternative treatment options.
I want to hear about your other two endometrial cases, but first, I'm just kind of curious where you think T-DXd is going to land in terms of metastatic disease for endometrial, because, I mean, in breast cancer, they're waiting on a trial that's looking at T-DM1 first line compared to the standard, which is chemo plus pertuzumab, trastuzumab. And I guess they're going to go ahead and use it, although using something that causes ILD in first line gives a little bit of a pause of thought, but there is a trial out there. Where do you could make the argument, even if it was better efficacy-wise, you don't want to expose them to the risk of ILD in first line. Any sense about, sort of best case scenario, the earliest we're going to be able to use it?
Well, I think there's a lot of conversations about, where are we going to ultimately be able to combine? And carboplatin paclitaxel is a really good regimen for metastatic recurrent uterine cancer. And so, do you take T-DXd and compare it to carboplatin paclitaxel? We don't think at the current time it's going to be easy to combine, and there are some trials out there, and maybe we'll say we can combine in the future, so they could use carboplatin T-DXd versus carboplatin paclitaxel. The other option is to utilize carboplatin paclitaxel and then bring T-DXd into a quote unquote maintenance type setting in those that are HER2 positive. So I think earlier lines of therapy are absolutely an option in the future, but the design of those clinical trials is quite challenging. And trying to take one drug and beat two is very difficult. Because again, carboplatin paclitaxel plus IO is pretty darn good, and we need to. So the design of the clinical trial is quite challenging, and most likely, I would be interested to see more of a maintenance type strategy. For example, with IO therapy, which we could combine it together with most likely not too much difficulties. Again, I mean, we'll have to wait and see and confirm that data, especially from ILD and pneumonitis. We don't see a big uptick with the utilization with IO.
All right. How about your lady who's in her 70s?
Well, I have a second lady here who is not lenvatinib pembro. I didn't include quite all the prior medical history, but this is a patient in her 70s. Once also came to our center for a second opinion. Her history dates back to 2016, and she actually has a long history of Crohn's disease and had multiple prior abdominal surgeries. So they couldn't do her surgery in a minimally invasive fashion. So they did open, and with that, removed her pelvic and lower aortic lymph nodes. She was without evidence of disease until she presented 5 years when she had a CAT scan finding a PET confirmed marked activity, and then biopsy ultimately confirmed recurrence. In this case, labeled as HER2 new positive, but now we just say HER2 positive, MMR intact. So she, at that time, upon recurrence, was referred to our center and was started treated on carboplatin and paclitaxel, in this case, Trastuzumab. She had to have a dose reduction based on some neuropathy with her chronic malnourishment. She presented with some baseline neuropathy, and then that had worsened. So we had a nice response after 3 cycles, confirmed after 6 cycles, and after the 6 cycles of carboplatin paclitaxel with Trastuzumab, she was then maintained on Trastuzumab for a year. And unfortunately, a year later, she had this lesion in her lung continue to increase in size. Now, she had other areas that were not, that were originally evident on the CT, but were not increasing size. So we actually resected this lesion in a minimally invasive fashion. And while she was recovering from the resection, because the resection tumor actually showed it was ER/PR positive, we continued her on anti-hormone AI, in this case letrozole, and she maintained that for 6 months, where then she presented with a pretty significant lesion. Now, because of her history of Crohn's disease, and this is a patient who has as a baseline more than 8 to 10 stool a day, lenvatinib pembro obviously was not something that we felt that would be in her best option. And so once again, we thought she had the opportunity to go on to a clinical trial, but when we were screened for it, the location of the lesion was felt to be too dangerous to biopsy. And so on the NCI trial, it would require a biopsy, a safe biopsy. So she was not eligible. So after having her all keyed up to go on to the trial, she was very interested in the drug. And so we applied for off-label and was approved for that. And unfortunately, she struggled. Her first cycle, she actually got admitted with neutropenic fever. Her diarrhea became almost unmanageable. So we ultimately have her down to 3.2 after 2 dose reductions. And at 3.2, she has had a really, really nice response. And I pulled the last CAT scan that I just saw her recently, and you see here she has essentially complete resolution of one of her lung lesions after the 9th cycle. So she's ongoing therapy right now. She's much better tolerated after 2 dose reductions, and is doing quite well. But again, GI, hematologic, fatigue really were a struggle for her, but now is doing quite well at the lower dose.
I was thinking about the fact that you mentioned diarrhea from T-DXd, and you were talking about like in mid-cycle, and I wonder if that is related to the primary tumor, the surgery, the abdomen. I don't think I've heard about diarrhea with T-DXd like that with the other cancers, but I'm not sure.
Well,
you say you see it in most people?
I don't know if I'd say it most, but I've seen it now multiple times. And is it because many of our patients have had radiation? They've had, or some of them have had radiation. It may be where we're seeing it more so. I think it's really, really interesting that the breast cancer practitioners are very worried with the previous radiation to the chest, pneumonitis, and we may be seeing again with the previous radiation, there may be something there. It's really interesting to potentially look at the differentiation of the GI side effects, for example, in the Pandestiny.
Interesting. All right, let's hear about your last case.
So this is we're going old school on this one, but it shows that she originally presented, she was in her young 60s, she's mid-60s now. Really interesting, typical presentation, postmenopausal bleeding. That for some reason they got in a PAP. PAP showed atypical glandular cells. They got an ultrasound, showed a lesion, and she finally had a biopsy. She probably should have the biopsy right when she presented postmenopausal bleeding, but that's a debate for another day. And it showed a serous cancer of the uterus. She was then referred to me, and she underwent robotic staging, and unfortunately became more than a staging, where she had fixed lymph nodes to the point where I was not able to remove all those lymph nodes because of how extensively the metastatic disease is, which is pretty rare in our center and really across the United States, that the metastatic disease is so bad we can't get them down to microscopic. So she had a fair amount of disease left at the end of her surgery. And we did, as all of her patients, she had mismatch repair proteins. They were all expressed, which you would expect. And I went back and looked at her IHC as I was preparing these cases, and all it says is positive. It doesn't say 3+, doesn't say 2+, doesn't say fish. So clearly this must have been 3+ because we didn't have fish on her. And she received 6 cycles carboplatin paclitaxel, then continued on trastuzumab maintenance. Because of the extensive nature of her disease, and really, I would have offered her at best 2-year overall survival with the amount of disease left behind. We did, she had such a nice response with chemotherapy that we did give her both pelvic and aortic radiation. And she continued the trastuzumab throughout that. Well, 6 years later, almost 6 years later, I guess 2020, I'm doing the math wrong. I'm sorry. I'm at 4 years, almost 4 years later, because it's almost 4 years anniversary coming up. She continues to be on trastuzumab. So now I'm in a position where I have a patient who's a walking miracle. And And I've had her on trastuzumab for 4 years. So the question really becomes, how long should we continue? In the trial that we participated in, that Dr. Fader led, we continued the trastuzumab indefinitely. So I've talked to her that I'll probably continue it for 5 to 7 years. She knows that she is a walking miracle, so she really doesn't want to discontinue it. But at some point, we're going to have to talk about discontinuing it. But she continues to be NED at this time and coming up on her 4-year anniversary. So the old drugs, I think they did provide benefit. I have not sent her for next generation sequencing. It'd be really interesting. Nor do we have P53. If she progresses in the future, obviously, I would test all of those. But this is a patient who has benefited from our previous treatment. I do think there is a potential role. There's clinical trials that we're enrolling, but not nearly as exciting as our current ADCs and current options moving forward. So pretty cool patient that is continuing to be in our practice.
That really is a great case, and also leads into something I was curious what your thoughts are on, which is the issue of sort of what qualifies for a pan-tumor or tumor-agnostic approval nowadays. Obviously, we have a bunch of them, and there are people saying or speculating that maybe T-DXd is going to fall into that category. And so, obviously all the time you see, very uncommon cancers you can't do a study on. Any thoughts about what it should take to get a pan-tumor approval? Or, if you had a patient right now who wasn't on the list, would you try it?
Well, it's a great question. And luckily our GYN tumors were on the list. I don't have to face that. I think off-label utilization of agents, as you know, my first choice is always clinical trial. But if you have a patient like the previous case that was not eligible for a clinical trial, utilizing mutations which are actionable is absolutely necessary at times. And I think particularly if I had a high expressor, I don't know how to define that, but if I had a high expressor, I think in other tumors that would absolutely be an option that I would have with the patient, discussion I have with the patient, and continue that option as a treatment. The pan tumor approvals, like MMR deficient for dostarlimab and pembrolizumab, I don't know if we'll see those to that degree. Now, we may see multiple tumors which get accelerated approval, but the FDA has led us to believe that even in those types of situations, they're going to need to have a confirmatory trial, and it would not be a final approval. Now, in those patients, in those tumor types, I shouldn't say patients, but tumor types that are expressed, that are so rare that they get orphan drug designation, that is an option where you can do single-arm trials, and that with very rare tumor, that there is a regulatory pathway forward. Currently, none of the GYN tumors meet that definition. And off the top of my head, I can't forget how many what the incidence is per year to meet that definition, but it's actually prevalence over how many patients are alive with that disease. So when we look at this, any tumor agnostic, quote unquote, would still need a confirmatory trial to show that it is better than the current standards available to our patients.
The challenge is so many people, as you were saying, are getting NGS once they get metastatic disease in a solid tumor that you see stuff, and sometimes you're not sure what to do about it. I've had so many cases present, you think about people who have BRCA germline mutations. Well, they get all kinds of cancers. And what are you going to see in their NGS? And then what are you going to do about it? I just believe it. You probably know this, but I did not. I just saw a paper on PARP in melanoma.
Yeah.
Have you ever heard of that?
Yeah. I mean, I think
objective responses in melanoma.
Rates. Yeah, I know.
It's objective responses to PARP in melanoma.
And it's pretty amazing. I have a patient in my practice with also uterine cancer, high grade uterine cancer that are BRCA mutation. And we were able to get a PARP inhibitor approved for her after carboplatin paclitaxel. And she's coming up to her 5-year anniversary with recurrent uterine cancer with no current evidence of disease. So absolutely have I done it. My first choice is get them on clinical trial. Let's learn about those patients in large spread clinical trials. Or I shouldn't say large spread, but across multiple patients, because the questions you're asking me right now about fish and about expression levels, the only way we're really going to answer that is if we do it prospectively, to your point. Right? So very important. But saying that, if a patient is not eligible for a clinical trial, then trying to get drugs, finding mutations which are actionable, we have a duty to our patients to talk to them about those options. And it's going to become more and more important to have these conversations and making sure we have plans for when we find these mutations.